Welcome back. In Inshort series, we'll be looking at the rheumatic fever and also highlighting a little on the rheumatic heart disease. So now I'm looking at what is the rheumatic fever. It is a systemic and it's post streptococcal, and important to note is it is non-suppurative inflammatory disease. Moving ahead, what it does is it affects all layers of the heart. That is nothing but pancarditis. And I would like to bring out the statement by William Boyd, that is, rheumatism, it licks the joint, whereas it bites the heart. Moving ahead, looking at the incidence, the disease it appears incidence mostly in children who are susceptible to the streptococcal infection and mainly around 5 to 10 years. But also previously we learnt about the MI, which is common in high socioeconomic status, whereas this rheumatic heart disease is common in poor socioeconomic strata. And looking at the common etiopathogenesis, here there can be environmental factors such as overcrowding as well as poor socioeconomic status as mentioned, as well as you can have family history, complaints of family history. These all comes under host factors such as family history, as well as in case of twins, and also genetic factor. And what it does is these factors they contribute to the streptococcal infections, and this is mainly with the A strain, and later it can lead to the rheumatic fever, the attack of rheumatic fever, and can also lead to recurrent rheumatic fever, and finally it leads to the rheumatic heart disease. So this recurrent rheumatic fever is caused due to recurrent streptococcal infection that is known. And looking at some of the immunological mechanisms which contribute here are autoimmune reaction as well as molecular mimicry and cross reactivity, and also exaggerated T cell mediated response. Now, moving ahead, we'll be looking at some important under microscopy what we are seeing. So an important point to be noted is presence of Ashkoff bodies. So Ashkoff bodies are nothing but they are spheroidal or fusiform in shape, and it is commonly found in interstitium of heart and can be visible through the naked eye, and it is commonly found in vicinity of small blood vessels, as well in the myocardium and the endocardium. Now looking at the stages, it evolves, and the stages are as follows. There is early stage, there is intermediate stage, and there is late stage. So talking about a few important characteristics, early stage presence, it takes place in the 14th week, the 4th week, and intermediate lasts from less than 13 week and the late less than 16 week. So under early stage, it is also known as fibrinoid stage, and I'll be explaining why. Degeneration. Here it's called as fibrinoid degeneration because the collagen fibers are degenerated. So collagen fibers are degenerated in this stage. And moving on to intermediate, here there is presence of NHCOW cells. You might ask whether these are the characteristics of RHD, but these cells are present normally in the heart and can also, in case of the rheumatic heart disease, it is more commonly found in large number. In case of the Ashkoff bodies, it's more present. Ashkoff bodies, it's high in number. And looking at some characteristics of this, they are large mononuclear cells. Let me just write it separately. That is NHCOW cells. They are large mononuclear cells, clear cells, and they have a central round nuclei, and also they have amphiphilic cytoplasm, and they have caterpillar like chromatin, and the nucleus is similar to that of the owl eye. So these are important points. And now I'm moving ahead to the late. In case of the late, what we are seeing is the Ashkoff body, it becomes less cellular, and there's increase in fibrocollagenal scar, and there's decreased cellularity as mentioned earlier. And now moving ahead to some of the extracellular lesions associated. So in case of extracellular lesions, there is presence of polyarthritis, subcutaneous nodules, there is erythema marginata, as well as rheumatic arthritis and chorea minor and rheumatic pneumonitis and pleuritis. Now there are also few criterias, that is minor and major. In under minor there is carditis, polyarthritis, chorea, erythema and subcutaneous nodules. Under minor criteria, this will be the major criteria. And looking at the minor criteria, there will be the fever, arthralgia, and also previous history of rheumatic fever, as well as laboratory findings such as increased ESR, increased C-reactive protein, as well as in ECG you will find increased PR interval. Now looking at some of the complications and what can it lead to. So here, in case of rheumatic heart disease, it can lead to cardiac failure, can lead to bacterial endocarditis, as well as embolism, and can lead to sudden death. Thank you. That's all with RHD, that is rheumatic heart disease. So thank you.